Very good morning to one and all of you. Today I'll be taking class on the next topic that is pyelonephritis. So pyelonephritis and reflex nephropathy will be the topics that we'll be discussing today. And coming to the definition of pyelonephritis, as you know, itis is inflammation and nephritis is the inflammation of the kidney. So Pyelo is something which is related to renal pelvis. So inflammation of the kidney and that is affecting the renal pelvis. And renal pelvis, what is the function of renal pelvis? It is a passage for the urine and the urine is coming from the renal tubules. Okay. So, from the glomerulus, the blood is filtered and then it goes into the urinary space from there to PCT and the loop of Henle, DCT, and then collecting duct. Okay. So now from the collecting duct, it was released to the renal papillae and then renal pelvis में urine is collected and then it goes to the ureter. Okay. So when the inflammation is affecting renal pelvis, it will get tracked onto tubules and interstitium. Okay. So pyelonephritis is the inflammation of the renal pelvis, tubules and interstitium, and it is a serious complication of UTI. As most of the diseases, it has an acute version and a chronic version. Acute version is sudden onset and it is mostly associated with UTI only. So UTI, when it is not resolved properly by antibiotics, so it can go into kidney infection. That is UTI which is concentrated in the bladder and urethra. If it is not cured properly, the infection can spread on to kidney. That is how acute pyelonephritis occurs. Chronic pyelonephritis, the same mechanism can be there, that is bacterial infection itself. And otherwise, when there is some obstructions chronically, there is renal stones, tumor, etc. That also chronic pyelonephritis can occur. Next is the etiopathogenesis. Etiopathogenesis is that 85% of the cases are caused by gram-negative bacilli, which is found normally in the GIT. That is, you imagine the GIT, all the feces are going through the anal orifice, and then your urethral orifice is comparatively near coming in the perineum. Okay, so if you are not maintaining the perineal hygiene properly, the coliform bacteria in the GIT can come into the urethra and infect, and that is how most commonly the UTI occurs. Okay, and that bacteria is so virulent, okay, that it can travel through the urinary tract and reach the kidney. Okay, so those bacteria are E. coli most common, as we all know, in the gut, and then there are Proteus, Klebsiella, and Enterobacter. Why gram negative? Because gram negative bacteria has a property and they have bacterial adherence property, which I'll be discussing later. And then in immunocompromised patients, see, normally when we have good immunity, our infections are contained. So in immunocompromised patient, less virulent organisms like polyomavirus, adenovirus, and CMV, which is not through the enteric pathway, can cause kidney infection. So there are two routes mainly for this infection to occur, that is hematogenous spread and the ascending infection. Hematogenous spread is through the bloodstream. That is in our body somewhere, either is infective endocarditis or dental abscess or brain abscess or TB or something. And then if that bacterial infection, if you're not cured by antibiotics, it can just spread into our blood causing septicemia. So when the septicemia, the blood is filtered through the kidney. So the bacteria reaches the kidney through the blood. And then when it is filtered, that bacteria can affect the kidney also. Okay, so that is how hematogenous route comes, and that is mainly caused in immunocompromised debilitated patients, and especially if septicemia is there, that can also be a complication. And then a ureteral obstruction is also there. Suppose the urine is also not flushing out, then the bacteria will more proliferate in the kidney. Okay, that is hematogenous route. Ascending infection from the lower urinary tract, which is the most common cause, that is from the urethra, it goes to urinary bladder, and then the infection spreads to the ureter to the kidney. So ascending infection, what are the steps? As you know, I said the urine mostly comes from the kidney, goes to ureter, then it comes to the bladder and then urethra. Okay. So just think the pathway, the reverse way. So first the bacteria will colonize the distal urethra or the introitus. Introitus means the opening of the urinary tract. So the bacteria colonizes there, and that is most commonly coliform bacteria. And usually the urine passes out and the bacteria or whatever waste products are flushed out. Okay, infection doesn't occur. But if you suppose the bacteria also should have a property to overcome this and get adhered to the introitus or the urethra. So those said the coliform bacteria have that bacterial adherence property because they have adhescence pili or fimbriae, the projections, okay, pili and fimbriae on their cell wall, which helps the bacteria to adhere to the urethral mucosa. Okay, so now the bacteria is adhered. Now from urethra to bladder it should go. Okay, normally urine will pass out all the bacteria and all, and infection is not caused. Okay, so if it has to reach the urethra, one way is through catheterization. Okay, because male urethra is so far, so for the urethra bacterial infection to reach bladder, you have to give some pathway, and one most common is through catheterization. You are giving an obstruction, and through the catheter also it can get infected. Okay. So if you are not doing the catheterization, especially the doctors or nurses, if they are not doing it properly or in sterile condition, or else also if you are catheter is there for long time and you're not maintaining hygiene, that time also patient can get UTI, which can later on cause kidney infection if not treated. So urethral catheterization is a way by which infection spreads from urethra to the bladder. Okay, so that is catheterization. Second is in females, because females have a very short urethra, only less distance the bacteria has to travel from the urethra to the bladder. One thing is that in males have prostatic fluid, okay, that has antibacterial property in it. So when that is absent, automatically there is less defense for females, okay, because we don't have that antibacterial property of the prostatic fluid. Second is because of our hormonal changes also the bacteria can adhere more, okay, because our vaginal pH is also there. Vagina is more near to the female urethra also. So our progesterone, estrogen and all can affect the pH, and that can help sometimes for bacteria to enter also. So now the infection has reached somehow to the bladder. Okay, now from the bladder to the kidney it has to reach. Okay, usually the urine passes from kidney to bladder. Okay, so what happens is that when there is some obstruction in the pathway, that is how urine will be stagnant in the bladder. Okay, suppose urine should be present in the bladder, then only it can backflow to the kidney. Okay, if it is normally getting flushed out when you are urinating, then it won't cause much infection. So there should be some obstruction, which should be some tumor, stones, or stricture or something in the bladder or in the ureter pathway. Then there is a chance that the urine can be stagnant and get infected. Second is vesico-ureteral reflex. Vesico-ureteral means from bladder to ureter, the urine should backflow. That is mainly happening by a valve. Okay, normally there is a valve which is connecting the ureter to the bladder. So when urine passes through the ureter to the bladder, it is normal. But when you are micturating, okay, or when you are urinating, this valve will close. So this urine will not backflow to the ureter normally, okay. But then what happens is that when the valve is defective, suppose by congenital abnormality or because those part is not at all developed or because of some infection or some other causes the valve is defective, then it will start backflowing. Okay, then now the urine will go to the ureter, and now the pressure is more, suppose in the bladder when you are micturating, the urine will backflow from the ureter till the kidney also. Intrarenal reflex in the kidney, now where it will go once the renal pelvis is filled with urine, then it will backflow back to the renal papillae, then to the collecting duct, then DCT, then loop of Henle, PCT, and then at last glomerulus also will be affected. So this is how the pathology is going from backwards. First urethra infected, then bladder, then ureter, then the kidney, then all of the kidney will be infected. First tubular interstitial part of the kidney will be affected, then the glomerulus, and then the whole kidney will be affected. So firstly, when urinary tract obstruction is caused, okay, the causes can be due to many things, mainly benign prostatic hypertrophy in hyperplasia. in the males, and then tumors of the bladder or stones in the bladder, and then neurogenic bladder. What happens in neurogenic bladder is that neurogenic bladder either can be due to diabetes, because diabetes people have diabetic neuropathy which affects the nerve, and that can cause urine, the reflex of micturition will be lost by the urinary bladder. Okay, what happens is that urine gets stagnant inside the bladder. And spinal cord injury also the same thing happens. Suppose the nerve that is supplying the bladder is transected or by trauma or some injury, then the nerve which has to go to the bladder to open the urinary orifice, and then urine is passed out. That is not happening. So what is happening is that then the urine will get stagnant in the bladder. So when urine is stagnant, there is chance for bacteria to proliferate in it, okay, and then that is infected. Usually, I said urine is cleared of the infection, urinary bladder is cleared of the infection when you pass out the urine. The bacteria will pass with it, but stagnant urine inside the bladder causes infection. Then is vesicoureteral reflex. I said the valves may be affected by congenital anomaly, or it is not developed at all. Okay. Or persons sometimes have short ureter. In that case, also the valve is not developed properly. That time there is high chance that the urine will backflow to the ureter. Okay. You should also understand this vesicoureteral reflex also spinal cord injury may it can be affected, because the valve also to function you need nerve directions. Okay, so the neural stimulus is not coming, so valve is not affected, valve is not working, then also the urine will backflow to the ureter. So you should understand that the urine is backflowing to the ureter not normally. You know, when waterfall occurs, water will go down. Okay, when you are pouring water, water won't go up, it will go down only. Okay, by Newton's law. Okay, so apple will fall down. The same way urine is also going down only, it will normally not go up and cause infection. So when does urine go above? Okay, when you are applying micturition pressure. Okay, when you want to urinate, that time you apply pressure. Okay, that time the urine will pass through the valve and then go to the ureter and the kidney. Okay, not normally it won't go properly. So when you are trying to micturate, that is when the urine passes backwards, and then the bacteria also will go through it. So intrarenal reflex, as I already said, it is the renal papillae which is open. So the from the papillae it goes to collecting duct, DCT, loop of Henle, PCT, etc. So what happens is that this also in the kidney, it mainly affects the upper poles and lower poles of the kidney. Why? Because the papillary end or papillary tip is flattened or it is concave. Okay, at the upper pole and the lower pole, but in the mid zones it is convex, it is little resistant, so the urine it is easier to flow backwards also through the flattened and concave tips. So you see then the kidney will be affected in the upper pole and the lower pole by the infection also. Okay. First, the urine will come and it will be dilated. The kidney will be dilated with the urine. Okay. So it will be hydronephrosis, you call it. And then the infection will slowly spread and then it will be filled with pus. So that time it will be called pyelonephrosis. Okay. So first hydronephrosis occurs because it is filled with urine. Kidney, renal, pelvis will get dilated, and then it will be infected by the bacteria and neutrophils will come and it will cause pus formation, and then you will get pyelonephrosis. So the test which we do to check for the uh, renal pyelonephritis or infection, or if there is backflow, is called voiding cystourethrogram. Okay, voiding cystourethrogram or micturition cystourethrogram. That is when you are trying to pass the urine, that time only the urine will backflow. Then only we can see the pathway. Okay. And so if you see here, a radio-opaque dye was injected into the bladder, and then you ask the patient to micturate or you ask the patient to urinate, and then you can see if the valve is defective, the urine is backflowing through the ureter into the kidney. Okay. In the kidney also you can see here the upper pole and the lower pole are affected first. It is dilated. Okay. And then later on the middle also will be affected. Okay, and then you suppose, see, if the urine is contained inside the bladder, it is only causing cystitis, and if urethra is affected, it is urethritis. Pyelonephritis will be caused only when the urine is backflowing through the vesicoureteral reflex. So if the valve is proper, then the infection is contained here only. There should be some mechanism or obstruction in this pathway. That is how infection should be spread and causing to the kidney. So this, as I said, there is hematogenous infection by septicemia, etc. And then second is ascending infection. Ascending infection, I said, first through urethra to the bladder, and then from here the vesico-urethral reflex goes like this. And in the kidney, renal pelvis will be dilated first, and then the urine will backflow to the renal papillae and tubules. So intrarenal reflex it is. So we will come into the two types, that is acute pyelonephritis first of all. So it is suppurative inflammation. Suppurative means pus forming inflammation. Why? Because most commonly it is bacteria. So wherever bacterial infection, neutrophils come to block it, and when neutrophils are degenerated, it forms pus. So there is suppurative inflammation by the of the kidney by mainly bacterial. Okay, very less chance of viral infection is also there. So there should be some causes, like you suppose in pregnancy, it can be in urinary tract obstruction, which I already said. Then gender and age in males due to congenital anomalies, there can be urethral valve and all. Okay, urethra mein there can be valve in males, sometime congenitally. That will cause obstruction in the urinary outflow, and it can cause urine to be stagnant and cause pyelonephritis. And then in younger age in females, that time hormonal difference can occur. Older age may what happens is that benign prostatic hypertrophy and catheterization is more common, and that is how urinary infection will spread to kidney. And then if there is any pre-existing renal lesions like obstruction due to stones or scarring, etc. And then diabetes mellitus, of course, there is diabetic neuropathy and neurogenic bladder, or else also diabetic patients are more susceptible to have infections because of increased sugar content. And then when there is immunodeficiency, obviously infections can occur anywhere, and kidney is also not spared. Clinical features, as you all know, what will happen in UTI, you will have a painful urination and burning sensation during maturation. So there is dysuria, that is painful urination, burning maturation, frequency and urgency. Frequency means you more frequently urinate, and urgency is that you cannot control the bladder. You want to go fast. These are normal UTI symptoms. What is happening in acute pyelonephritis is that you will have also costovertebral angle pain and tenderness. Okay, costovertebral angle in the back side of our body. Okay, posterior side of the body, the vertebrae is here, and the costal or the the ribs are there. The rib margin is the costal margin. So the costal margin and the vertebra. So this angle, costovertebral angle, the renal angle. So there the patient will be having pain, and if you press and see, there will be tenderness also. Because it is infection, patient will obviously have fever and malaise. So when you have the UTI symptoms along with the renal symptoms, that time you should suspect acute pyelonephritis. CBC, because bacterial infection, you will have increased neutrophils. And urine may you will have pus or leukocytes. Pus, I said, it is degenerated neutrophils. So neutrophils are WBC. So you will get neutrophils and WBCs and pus mainly in the urine, which is indicative of UTI only. But when you start getting WBC cast, because cast, I said in last class, it is formed when some substances are accumulated in the tubules and they will get a cylindrical shape, because that accumulation is passing through the tubules, okay, like a cylindrical shape. So when pus is accumulated or WBC is accumulated in the tubules, you will get pus cast, okay, that will pass through the tubules and will come to the urine. Normal UTI, you will get pus in urine. If you will get cast also, you should suppose the patient has kidney infection also. So this is how pus in the urine looks like, and this is how the urine will look like, some yellowish, greenish kind of. And acute pyelonephritis, grossly what you will see is the kidney has abscess or pus points on the capsule. Okay, capsule and the kidney parenchyma. One kidney can be affected or both the kidney also can be affected. And then in microscopy, what you will see, as I said, it is acute inflammation of the tubules, interstitium, and the pelvis. So the tubule, if you're supposed, it will be filled with acute inflammatory infiltrate, that is neutrophils, and even the tubule wall also will be having neutrophils, and the interstitium also will be having neutrophils. So as the name suggests, inflammation, that is acute inflammatory infiltrate, that is neutrophils, will be present in the tubules, in the tubule wall, and in the interstitium also. The next, acute pyelonephritis has three complications. Okay, first is papillary necrosis, Second is pyonephrosis. Third is perinephric abscess. Papillary necrosis, renal papillae. Okay, so at some conditions, the papillae is the first part which will get necrosis, because all the urine is backflowing through the renal papillae to the tubules. So when there is so much of urine going through that, at last the papillary part will get necrosed. Okay, so this is a complication of pyelonephritis, and which is most commonly seen when patient is having diabetes, sickle cell disease, or especially in pregnancy also you can get papillary necrosis. Okay, so the distal two-third of the pyramids, pyramids or renal medulla will be affected by papillary necrosis, and it is a type of ischemic or coagulative necrosis. Okay, because most of the time it is going, the blood supply in that part will be cut off and there will be coagulating necrosis. And then second is pyonephrosis. I said there is urinary tract is obstructed and the urine is fully getting collected and getting stagnant and backflowing and dilating the renal pelvis, and then now the renal pelvis is fully dilated and it is affecting the kidney fully, and then now the urine is filled, then it is called hydronephrosis, and then later on infection is coming, pus is filled in the renal pelvis, calyces, etc., it is called pyonephrosis. Hydronephrosis, when it is fully filled with urine and it is dilated. Okay, now kidney is not passing out urine because somewhere some obstruction is there. So the urine is fully collected there only, and then it is getting infected. After infected, which is filled with pus, it is called pyonephrosis. Then perinephric abscess. Peri means around the kidney there is abscess. Already the abscess has affected kidney when there is pyelonephritis. Now it crosses the fat and gyrotose fascia and it is infecting the surrounding tissue by suppurative inflammation. Then it is called perinephric abscess. So three complications: papillary necrosis, pyonephrosis, and perinephric abscess. So this is a picture of papillary necrosis. As you can see, this is the kidney. So this is the renal medulla, and here you can see this white area, which is the papillary necrosis. In microscopy, you can see this thing that is in renal medulla. The distal two-third or one-third will be affected by coagulative necrosis. How you will identify a necrosed tissue? It will be only pink color. There won't be nucleus. Okay, that is how you identify a necrosed tissue. Then what happens in healing phase? Acute inflammatory infiltrate will be replaced by macrophages, lymphocytes, plasma cells. Okay. And if this is not resolved, it will go into chronic pyelonephritis. And then later on, there can be scarring and all of the kidney. Prognosis wise, if it is an infection, you have to give antibiotic therapy. If there is recurrent infection, you have to check for what is the cause. Okay, if there is obstruction like stones or some valvular issue, or patient is having diabetes or immunodeficiency, this thing will happen again and again. Okay, so just by treating pyelonephritis, it is not going to get solved. So you should treat the underlying cause also. So if the patient is having recurrent or non-resolving pyelonephritis, check for the causes of the infection. Okay, and then papillary necrosis also, if not treated, it can go into acute renal failure. One thing you have to also know is about polyoma virus nephropathy. What is polyoma virus nephropathy? Polyoma virus is usually a less virulent virus. Okay, normally in a very immunocompetent patient it won't be affected, but in kidney allografts. Okay, what is allograft? Allograft is means a transplant which is you are taking from other person. Autograft means your own tissue you are taking it. Okay, like urine blood you can use for the surgery and all. Syn graft is similar tissue. Like the same way, allograft is from a different person. Okay, so kidney allograft, like kidney transplantation time, what happens it is that reactivation of the latent infection occurs. Why? Because see, normally if I was a normal person and I had polyoma virus, but because of my immunity, the infection was contained. Okay, what happened is that after my death, I had written for kidney transplantation and my kidney went to somewhere else. Okay. But that person has been in immunosuppressive drugs to accept the kidney. Okay. So when you are in an immunosuppressive state and accepting the kidney and there was polyoma virus already staying there, it will now reactivate and cause latent infection. That time what to do is that you should not take out the kidney now, because after so much of difficulty you had transplanted it. You have to just reduce the immunosuppressive drug dose so that your immunity can act upon it and then contain the infection. So if there is a polyomavirus nephropathy, this is how microscopy looks like. Okay, in the kidney tubules, you can see viral inclusions. In electron microscopy, it will look like this. Chronic pyelonephritis. Okay, chronic pyelonephritis is the same thing. Tubules, interstitium, and the renal pelvis is affected by chronic inflammation. And then later on, there will be scarring of the calyces and pelvis. So there is chronic inflammation of tubules, interstitium, and the renal pelvis. And then there is scarring of the calyces and the pelvis. So important cause of kidney destruction in children with lower urinary tract abnormality. Okay, so when abnormality is not treated, the infection will go into chronic phase. So that is how in children, if there is urinary tract abnormality, they can go into CPN or chronic pyelonephritis. So there are two forms of chronic pyelonephritis. One is reflex nephropathy, other is chronic obstructive pyelonephritis. Reflex nephropathy, I said when the valve is not working properly, the urine will go back. Okay, so that is how reflex nephropathy occurs. When there is obstruction also, after so much of urine is filled also, the valve will automatically open and go back. Okay, that is obstructive pyelonephritis. Reflex nephropathy, reflex occurs both cases in obstructive also in reflex nephropathy also. But you suppose ki if there is no obstruction also, if the valve is affected, then also reflex can occur. Okay, so reflex is a condition which can occur in obstruction also, but reflex purely also can occur when valve is affected or when there is. And then there will be vesicoureteral reflex and intrarenal reflex. Okay, so when the obstruction is there, first it will be sterile reflex, that is urine is going along only. Then later on it will get infected. Chronic obstructive pyelonephritis, as I said, because of calculi or prostatic hyperplasia or in बच्चों में, that is in small children, there can be posterior urethral valve. What is posterior urethral valve? It is a very important condition that you have to rule out in a child. Okay, so if a male child is coming who is not properly passing the urine with a proper stream, okay, males have a stream while passing the urine, not like females. So if they are not maintaining the proper stream like that, if the mother is complaining, then you have to do radiology and check whether the patient is having posterior urethral valve. Normally, this valve undergoes like it will just won't be present after the patient is developed fully. Okay, fetus, or it is an anomaly, you can tell if it is persistent in a child. Okay, this valve is like this, or this is the bladder, and when urine is passing, this valve will be obstructing it so that it cannot pass fully the urine. Okay, can be partial obstruction or complete obstruction also. So because of that, the urine will get accumulated and accumulated and accumulated, and it will backflow to both the ureter and both the kidney, and both the kidneys will be affected, and the patient will go into renal failure. And then the treatment is only renal transplantation. Okay, so it is very important that you find the condition as early as possible. And then chronic pyelonephritis, that is the condition which I am discussing. Grossly, what you will see, I said there will be scarring because of chronic inflammation. The kidney is healing those areas of infection by forming the scars. And then microscopy, you will see thyroidization of tubules and dilatation of the tubules. Okay, so this is the gross picture. Okay, you can see the scarring here. Okay, see the renal pelvis is fully dilated. I said because urine is fully accumulating, that time the renal pelvis will be dilated. You can see the cortex is thinned out. Okay, and then what happens, then it will be filled with pus. Okay, it will be filled with pus, and then you will get, it will be healed by forming this irregular scars. Normally the kidney surface you will get little lobes and it will be smooth, but there is no scars as such. Okay, cut surface, what you will see is because the urine is accumulated and the host tam host wall protein is accumulated in the tubules because of the tubular injury, there will be thyroidization of the tubules. Okay, you can see the thyroidization of the tubules. Why it is called thyroidization is because histology of the thyroid also looks similar only. Okay, you know, like colloid is present in the follicles. In the same way, you can see the thyroidization of the tubules, and you can see in the renal medulla, all the tubules are very much dilated. Why? Because there is fully stasis of the urine. Because of that, there is dilated tubules, cortex is totally thinned out, and then there is thyroidization of the tubules. And if you can see chronic inflammation at places also. So if you're seeing histology, you will see thyroidization of the tubules and then dilatation of the tubules, and then it is chronic inflammation of the tubules and interstitium. So you can see chronic inflammatory infiltrate, that is lymphocytes in the interstitium and tubules. And you know, when after all the tubules, at last glomerulus also will be affected because urine will get stagnant and push the glomerulus also. So now the glomerulus also undergoes sclerosis and then periglomerular fibrosis. Okay, so these are the features of chronic pyelonephritis. Firstly, you will get thyroidization of the tubules because protein gets accumulated due to tubular injury. Okay, tubular injury, tubule gets necrosed, and then there will be TAM host wall protein and secretions, everything will come inside, and urine also is stagnant in the tubules. Because of that, it will look like a colloid. Okay, so it is thyroidization of the tubules, dilatation of the tubules, and then there is chronic inflammatory infiltrate in the interstitium. Then glomerulus, you will have sclerosis and periglomerular fibrosis. So I said clinical features, if there is obstruction, obviously the urine flow will be decreased. Okay, but whatever little bit urine will be there, it will be infected by bacteria and pus. Okay, and the patient will be having costovertebral angle pain, fever, etc. Reflex nephropathy mein what happens is that here obstruction is not there, so urine is flowing, and tubules and the interstitium are affected. So tubular function is to concentrate the urine, and that is not happening. So the patient will have polyuria and nocturia. Okay. Radiography, I said you will do micturition cystourethrogram also you can do in this case, and later on you can do normal radiology also. You will get asymmetrically contracted kidney. Means both the kidney there will be symmetric, it won't be symmetrical. You will have scars somewhere which won't be same in both the kidney. Polynephritic scars you will get, means many scars you will get, and there also later on the patient will have focal segmental glomerulosclerosis, and at last it will go to end stage renal disease, that is chronic renal failure. So acute pyelonephritis, if it is not treated properly, it can go into chronic pyelonephritis or acute renal failure, and chronic pyelonephritis will go into chronic renal failure. So in radiology, you can see like this, okay? So see the scar, how it is, and because of the different scars that are formed, like it is healing in different stages, you will see asymmetrically contracted kidney. So now just summarize this thing which we studied today. So we study there are two types of pyelonephritis, that is acute pyelonephritis and chronic pyelonephritis. And pyelonephritis is the inflammation of the renal pelvis, tubules and the interstitium. Okay. E2 pathogenesis mainly hematogenous infection or ascending infection. Hematogenous through the bloodstream after septicemia. Ascending infection through the introitus, urethra, urinary bladder, ureter and kidney. Steps of ascending infection, as I said already, that will colonize the introitus and urethra, and then from urethra it will go to the bladder. From bladder, then vesicoureteral reflex to kidney, and in kidney there will be intrarenal reflex. Acute pyelonephritis etiology, the same ascending infection and the hematogenous spread. I mean, mainly it is bacterial, and then a little bit of viral also it can be there. Clinical features: costovertebral angle, pain, tenderness, dysuria, frequency, micturition, burning micturition, urgency, and then fever, malaise, etc. Morphologically, grossly, you will see abscess or pus points in the renal pelvis, in the renal parenchyma and the capsule, etc. And then through the cut surface, you will see acute inflammatory infiltrate, that is neutrophils inside the tubules and in the interstitium. Complication of acute pyelonephritis are papillary necrosis, pyonephrosis, and perinephric abscess. Prognosis: if you are giving antibiotic treatment, it should get resolved unless it is not caused by some other underlying causes like diabetes, spinal cord injury, or some urinary tract obstruction by stones, tumor, etc. Then you have to treat that also, like benign prostatic hyperplasia, and only you have to treat. Then only infection will be fully resolved. Chronic pyelonephritis, there are two forms, that is reflex nephropathy and then there is chronic obstructive pyelonephritis. Morphologically, grossly, you will see scarring of the kidney, And in cut surface, that is microscopy, you will see thyroidization of the tubules, dilatation of the tubules. You will see chronic inflammatory infiltrate in the interstitium. Then glomerulus also will be affected at last by glomerular sclerosis and periglomerular fibrosis. Clinical features almost same as the acute pyelonephritis only. Prognosis wise, if you're not treating properly, the patient will go into chronic renal failure or end stage renal disease. Okay, then at last only renal transplantation you can do. So thank you all. Kindly do subscribe, share and like and comment if you have any doubts or if you want me to discuss any topics. Thank you. Have a nice day.